That's fantastic. Thank you very much for the introduction, Dell. Dell and I were just speaking, and it feels very strange not only to be around so many people, but also to be giving a talk wearing a pair of long trousers, because it's been business on the top, party on the bottom for the last 18 months, as we say in New Zealand. So I had to buy a couple of new suits, actually, recently, because the lockdown 5, apparently the average Brit has put on 5 kilos during the lockdown, and I was in that group. So, look, I've been asked to give a talk on real-life data on some of the newer drug therapies that we're using in MS, and I thank you to the organisers for thinking of me. It was a bit of a heart sink, because normally when you give talks you think, yeah, I've got heaps of slides already and it'll be a bit of a copy and paste job, but actually this is a totally new topic for me. I've never given a talk on this topic before, so I hope it's of interest. And my pointer doesn't work. Am I doing the right thing, AV guys? Yeah, perfect.
There's a separate pointer.
Oh, well, I think this one's working now anyway, so that's great. These are my disclosures. I've got disclosures of pretty much all the drugs I'm going to be talking about today, so I don't have one in particular. And really, when I was given the topic, these were the 3 things that came to mind. Firstly, to try and define and give you an idea for what we might consider real-world evidence to be, as opposed to the evidence that we collect formally in the context of, say, randomised controlled trials. How do the newer MS drugs stack up in clinical practice? So we've had a real explosion of new therapies in the last 5 to 10 years, and that's going to continue for a little while, but how do they actually work in real life? And how does real-world evidence inform your practice, or how could it inform your practice? And I've just picked 5 scenarios or 5 areas that I think about quite a lot, and I'm going to share with you some fairly recent real-world evidence that helps address some of these issues. And so this is the dilemma that we face, right? And it's a good one, that we've got lots of treatment options for our patients. Some of you will be MS nurse specialist part-time and then do Parkinson's disease or motor neuron disease or other neurological diseases as well. You're more skilled than many of the consultants. But many other neurological conditions, there just isn't this range of therapy options available, and this has been a tremendous success. But with it has come a bit of a headache as to how best should we use these drugs. And this figure is from a review article we did a few years ago for the BMJ, which was very rapidly out of date, because as you can see, since this was published in 2018, there have been 4 new drugs approved for MS in Europe, 2 of which I'm actively prescribing for patients. At least here in England, we don't have access to ozanimod or ponesimod. So randomised controlled trials are often regarded as being the pinnacle of evidence to support clinical decision making. But they do have some limitations, and they aren't the be-all and end-all. So the first of these is the sorts of patients who are enrolled in clinical trials aren't the sorts of people who necessarily come to clinic. So when you're recruiting for a clinical trial, you generally pick the best, easiest, laid-back patients that you've got. And that's partly because of the inclusion criteria for trials. They say we can't recruit people over 55 in most clinical trials. They don't like, we were told not to recruit people who've got comorbidities, for example. And often if people have had MS for a long time, or they've been on a number of lines of different disease-modifying therapy, they will be excluded from clinical trials. Whereas those patients actually populate our clinic, we see them all the time. Another disadvantage of trials is they're typically of short duration. You can't have people coming up for trial visits every month or every 3 months forever. And trials typically run for 2 or 3 years, and then a readout happens to say, yes, this is a good thing to be doing, and people get unblinded and everyone moves on to the latest and the greatest drug. But because of that, we're left with uncertainty as to the long-term benefits and the long-term risks of our therapies. And thinking about long-term benefits of drugs, the UK has unfortunately the shame of having to carry the risk-sharing scheme, and people believed for ages that MS drugs didn't work, and we had to do the risk-sharing scheme to allow patients to access beta interferon in the past, when the rest of the world were getting on and treating MS. That's of course changed now. But real-world evidence like the risk-sharing scheme is a way of showing that these treatments are beneficial in the longer term. And finally, real-world evidence can give answers to questions that just can't be answered by clinical trials, things to do with MS disease course, pregnancy, how to sequence different disease-modifying therapies. So these are just some definitions that I came across for what real-world data means and what real-world evidence is. So real-world data is data generated in routine clinical practice that captures an individual's health status or health service use. And real-world evidence is really using that information that's gathered as part of routine clinical care for research to be analysed to generate real-world evidence. And this can come in a whole raft of different ways. So it might be a disease registry, and I guess the stars of registries in the MS space are MS Base, which is based in Melbourne. I'm not Australian, I'm from New Zealand. That's just so no one makes that mistake in the break. And then major disease registries in Scandinavia, where they're just incredible about collecting information about their patients in Sweden and Denmark. And there's also registries in Italy and France that are very active. You can collect data from electronic health records. So at UCLH, where I work, we've got EPIC, which is an electronic health record that stores our patients' information, and the data can be collected from that. There's health claims databases, like all those things that we put into BlueTech. Actually, that can be used to generate real-world evidence. I've got an example of a study of that from the BlueTech database. And then biobanks, collections of MRI scans that are done as part of routine care, or OCT scans, or lumbar punctures and body fluids. And so the newer MS drugs, how do they stack up in the real world? Are they performing as we might expect? And I came across this systematic review of real-world studies published on some of the newer MS DMTs. Of course, this was published in 2021, and the list doesn't include a lot of the other DMTs we're using now, like siponimod and ofatumumab as well. But they were able to include drugs like fingolamod, teriflunomide, dimethyl fumarate, alemtuzumab, ocrelizumab, drugs that were approved a few years ago now. And actually, generally, in real-world studies, the efficacy of the drugs that we use often comes out better, if anything, than we might expect from the clinical trials. And that's not necessarily because the drugs are more effective, it's just that maybe we're not necessarily as good at capturing things in routine clinical practice. Was there a new T2 lesion on the scan? Was that a relapse, or was it a pseudo-relapse? Things aren't maybe collected in quite the same way, but overall it's a reassuring story that the drugs perform well. Importantly, real-world evidence has also demonstrated new safety signals for the drug, and I think everyone's aware of the story with alemtuzumab and the various concerns with the use of that drug that weren't apparent until the drug was in widespread clinical use. Real-world evidence also helped define some rare risks of other drugs like fingolamod or dimethyl fumarate, where there weren't cases of PML in the clinical trial program. In the initial clinical trial program rather than the extension, I should say. Now, another drug that wasn't able to be reviewed on that list was cladribine, and I thought that maybe I'd just choose that one. And this is how cladribine performed in patients with high disease activity in the clinical trial program, the Clarity study. There was a 67% reduction in relapses and a 92% reduction in GAD-enhancing lesions. And how does it perform in the real world? So this is an example of a real-world evidence study evaluating the use of cladribine. And this was 270 patients initiating cladribine at 2 MS centres in Germany. They were using the drug in a slightly different way, I think, from the way that I use it, but practice varies a great deal around the country, but only a third of people were using cladribine as their first DMT. In my practice, that's more like 70-80% use it as their first DMT. And what was seen, mirroring the clinical trial program, is that there was a profound reduction in relapses, which you can see here, and a profound reduction in new T2 lesions on MRI. So similar results to what we were expecting from the clinical trial program, reassurance. In terms of safety, a similar number of people developed grade 4 lymphopenia with cladribine, that being obviously the most worrying of side effects, around about 1% of people. But shingles was considerably more common actually in this real-world cohort, which is interesting, because in the real world we are treating older people, people with comorbidities, people that have had more DMT in the past, 2/3 of patients in this study, and so this is something to think about and keep an eye on. This is our own experience with cladribine at Queen Square. This is the first 150 patients we initiated after the drug was launched at our centre. Over half of them were treatment naive, and relapse rates fell in that first year of cladribine treatment from an average number of relapses per year of 1.71 to 0.18, and about 2/3, 60% of patients had no evidence of disease activity out in the first year of treatment, shown here. Again, we found similar rates of grade 4 lymphopenia as to the German study, and shingles was more closely aligned to what was seen in the clinical trial program in our hands. Okay, so hopefully I've told you so far what real-world data and real-world evidence is, and given you a flavour for how real-world evidence can support the findings or the place of disease-modifying therapies in our therapeutic armamentarium. That's all well and good, and it's always nice to hear that, actually in the real world the drug does what it says on the box and things are going well. But actually what's more useful in my practice is when real-world evidence is able to answer and address questions that can't necessarily be addressed in clinical trials. And these are 5 questions or 5 issues that come up regularly in my practice. I'm going to illustrate each with a short case history. So the first case is a 29-year-old woman who's recently diagnosed with MS after an episode of optic neuritis. She's got an abnormal brain MRI and CSF-specific oligoclonal bands, and she's been looking at MS decisions, and she's trying to decide whether to initiate Tecfidera or Ocrevus. Now, these two are going to give you the answer to what you should do in that situation, because you've got 2 other talks coming up this afternoon about how we should treat early MS. So Will's going to talk about work from the MS-based registry, I think, that he's been involved with, and Nikos is going to talk about the ongoing Deliver MS study. Since I'm talking first, I'm going to make a couple of comments myself, which that's the benefit of being earlier in the program. And the first is to share this very recent paper with you that was only published about 10 days ago or so, and certainly has generated quite a lot of interest. And it's a combined effort of the Swedish and the Danish MS registries. And in Sweden, about 70% of people with MS are on this registry. In Denmark, I think it's about 80% of people with MS. So it's the data that's being collected by doctors, nurses, pharmacists involved in the care of people with MS in Sweden and Denmark is all entered into the registry. And it's generated tremendously useful information like this study. Now, Sweden and Denmark are similar in terms of their socioeconomic status, the nature of their healthcare system, geography, but they're quite different, apparently, in the way they treat MS. So in Sweden, MS neurologists have, over the last few years, become increasingly aggressive in the way they treat MS, and a higher proportion of neurologists treat with an early intensive treatment paradigm. Now that contrasts with Denmark, where actually neurologists feel more comfortable with an escalation approach, starting with a less effective treatment and building up in patients who need it. And I was interested that actually in Denmark, reading this paper, which I had no idea, the most commonly prescribed DMT in Denmark is teriflunomide. Nearly half of people initiating a DMT go on to teriflunomide, and that's so different from practice in the UK. Now, they looked at nearly 5,000 people who were starting their first DMT between 2013 and 2016. So this is one of the drawbacks of real-world evidence, is you have to wait a while to generate it. It doesn't come immediately. And they followed up patients for 4 years. And they looked at how people did if they were Swedish versus how people did if they were Danish. And this is what happened in terms of the proportion of people who remained free of disability progression. And you can see people with MS who were treated in Denmark compared with people with MS treated in Sweden were not doing so well at the end of 4 years. So just being treated in Sweden was associated with a 29% reduction in your risk of confirmed disability progression over about a 6-month period, and a 24% reduction in reaching EDSS-3, which is one of those sort of key milestones the natural history studies tell us once you get to EDSS-3, you're actually starting to get on the skids and things may not go so well. And importantly, and I think actually probably one of the most important outcomes in a real-world evidence study is discontinuation of DMT, because people stop their treatment if it's not going well, either because it's not working or if they don't tolerate their treatment. And actually, in my mind, that's really, really important, because if we've got a treatment that is associated with a 99% reduction in relapses but patients feel awful on it, they're not going to take it. And so I like seeing that as an outcome in these real-world studies. And it being treated in Sweden was associated with a 22% reduction in your risk of discontinuing a DMT. And the study, which others may talk about this afternoon in more detail, we haven't been very good at coordinating our talks, so I hope there's no repetition. But this study really is more evidence about the importance of being active and treating MS early and effectively. Now, Stacey Pruitt's in the audience somewhere. I know she is because I saw her at lunch break. There you go. Are there any other paediatric MS nurses in the audience? Oh, fantastic. Like little clump over there. And this is work from the UK Childhood Inflammatory Diseases Network that I'm part of, and Stacey from work with young people with MS at Great Ormond Street. And this is a real-world study from BlueTech. And I put this in firstly because I think it's important to not forget that kids get MS as well and give everyone an update, because newsflash, they all turn 18 and are going to become your problem at some point. But secondly, because it's, BlueTech forms are a real pain. I'm not sure who does BlueTech forms here, but we've got really strict pharmacists and they make the consultants do them at our hospital, and I really don't like it. So it's actually really nice when I think all this time I'm spending putting all this stuff into BlueTech actually might come up with some useful information. And so this is a really nice study led by Omar Abdul Manan, who's doing a PhD between Queen Square and Great Ormond Street. And he looked back at 103 people, 103 children who initiated disease-modifying therapy in the UK and had follow-up of 4 years. And roughly half the kids started with an injectable DMT and half of them one of the newer DMTs. And if you went onto a newer DMT, so that's Tecfidera and beyond, and you guys might be thinking, oh, Tecfidera is not that new for me, but don't forget, for children, the evidence takes longer to stream down because until recently there haven't been any trials. And you can see what happened here in terms of annualized relapse rate in kids who had an injectable. If anything, it went up with the treatment rather than going down. And this is annualized relapse rate in kids that went on to a newer DMT, so an oral or a monoclonal antibody therapy. And actually being on one of the newer DMTs was associated with a 12-fold reduction in the risk of a relapse and a 2-fold reduction in the risk of new lesions on MRI. And importantly, my favourite thing, children were less likely to discontinue one of the newer DMTs compared with an injectable. This is relapses here. You can see the relapses just bottoming out and people on one of the newer drugs and continuing over time. in people on an injectable DMT. Okay, second question that comes up a lot in my practice. Is one oral medicine better than the others? So a 44-year-old man is considering starting an oral treatment for MS following a recent relapse, and he's unsure whether to go on dimethyl fumarate or teriflunomide. He's eligible for both. And he asks you, well, how do the two medicines stack up? Now, there has never been a clinical trial comparing dimethyl fumarate and teriflunomide, and there's never going to be. So real-world evidence is really the only way we can hope to answer this question. And there's been quite a few, when I sort of went back and reviewed this, this has been addressed quite a few times, quite a few different registries, with all with sort of slightly different findings. But this, I think, was the best study that I found of the 4 or 5 that have addressed this question. And this is from OFSEP, which is the MS registry in France. Sclerose en plaques, that's the SCP bit. And they looked at 1,770 patients initiating dimethyl fumarate or teriflunomide, of whom about half were treatment naive. And I feel like that's an important thing to say because they're the sort of patients I would be thinking about using these drugs, and I probably wouldn't give these drugs to people as a injectable, then an oral, then something else. So if I was going to use these, it would be as a first DMT. The proportion of patients with relapses or disability progression was actually very similar between the two drugs. And you can see that here. There wasn't much difference over time. But patients who were treated with dimethyl fumarate had better MRI outcomes at 2 years. And I don't know what your view is, but I think many people sort of think about teriflunomide as being more at the similar level of efficacy as an injectable, and maybe dimethyl fumarate a small step above that. And I guess that this research would suggest that that's probably about right. But importantly, more people stopped dimethyl fumarate. So almost over 1 in 5 people that went on to dimethyl fumarate came off because of side effects, as opposed to 16% of people with teriflunomide. And I think that is something relevant we need to think of for our practice. What about selecting second-line oral DMTs? So Fingolamod, which of course we can use after failure of an injectable, or Cladra, which is also licensed in those situations. This is a study from MS Base. In Australia, Mavenclad, used to be called Mavectro, was approved about a decade ago and then was withdrawn because it wasn't approved elsewhere in the world. And so a small number of people, 37, actually had some experience with Cladra before everyone else. And this is a small study, just 37 Cladra treated patients, 1,800 treated with Fingolamod, and there was propensity score matching, which I think I'm sure Will's going to go into a bit later, which is a fancy way of making sure the people you're analysing are all kind of similar. And the risk of relapse and disability progression was similar between the two drugs. But people treated with Cladra were a bit more likely to have an improvement in their disability. Hard to know how to interpret that. We've just recently completed a real-world evidence study here in the UK, the Merlin MS study, which is a head-to-head real-world evidence comparison between Fingolamod and Cladra. I can't share the results with you today, but they're going to be presented at the American Academy of Neurology next year. Look out for that. Switching therapies. In people who are stopping natalizumab, these patients are a headache, aren't they? Someone's JCV positive, and they're worried about PML, you're worried about PML, they're worried about switching their treatment, you're worried about switching their treatment. It's these people can be complicated. So this is just one of my patients, but I'm sure you've all got one similar. A 39-year-old woman concerned about her PML risk. She's received 108 infusions of natalizumab. Her JCV index has recently increased, leaving her in the 1 in 100 group. And she's really concerned about experiencing a relapse because she remembers what MS was like before she went on natalizumab, or a progression of disability, having been well for so many years on natalizumab. And this is something that we have to do quite a lot, unfortunately. So this is a real-world evidence study from the VU Medical Centre in Amsterdam. where they looked at 253 consecutive patients who went on to Tysabri, and 70% of them had to discontinue their treatment. And people stopped the treatment for a variety of reasons, but the main one is because of JCV positivity and PML risk. Unfortunately, a few stopped treatment because they actually got PML, which is not great. And treatment decisions are complicated because when you do switch people off Tysabri, you're nervous about a reactivation of disease or rebound disease activity. And patients are often nervous because often, or generally, they've been stable for a long period and they're worried about what's going to happen next. And I don't think, in my mind, there's an optimal strategy for switching patients off Tysabri onto other DMTs. And I think that's illustrated in this real-world evidence study. These are the 147 who stopped Tysabri, and these are the other drugs that they went on to, and it's a real mess, isn't it? Some went on to Fingolamod, which some people are still doing, but that was very popular 5 years ago. Ocrelizumab, which certainly is something I've done quite a lot more recently. A few people took a bit of a step down and went on to tablets and injections. I've not done that myself. A few people stopped DMT altogether, which I think is a bit brave if you're on Tysabri. But you can see actually when they followed the patients up, many of them ended up going on to other DMTs too. So it was a bit of a complicated path for these patients coming off Tysabri. So what evidence do we have about how to switch people off natalizumab? Well, this is a nice study from the Italian register, a bit old now, 2015. But they looked at 433 people who were coming off Tysabri mainly because of PML risk. And some switched to an injectable, which I think was obviously a popular thing to do before Fingolamod became available in the UK in 2013, 2014. And then some people, once Fingolamod became available, switched to that. And again, they were matched with this propensity score matching. And actually, if you went on to Fingolamod, which is in red, versus brace therapy, I can never remember all that, but that's just all the injectables, including Copaxone. Well, I can never remember all the names. But those people did worse and had a much higher risk of a relapse. If you left people off Tysabri for more than 12 weeks, which again I don't think we would do now, but people were doing routinely a few years ago, then those people were about double the risk of having a relapse. So this study taught us that if you're going to take people off Tysabri, move on to another high efficacy drug like Fingolamod. If you are going to stop Tysabri and move on to another drug, do it all quite quickly. Don't take your time. And these are a couple of additional studies that have become available over the last couple of years that have informed our practice. This is in people discontinuing Tysabri. It looks like going on to Lemtrada might be more effective than going on to Fingolamod in terms of the proportion of patients who get away without having a relapse. This is data from Sweden, again, where they love rituximab. We don't use rituximab for MS, but we do have access to two other B-cell depleting therapies in the UK, ocrelizumab and ofatumumab. And we could make a bit of a jump and translate these results potentially, but rituximab patients were very, very much less likely to experience a relapse, this is on the left, or adverse events leading them to stop their therapy compared with patients going on to Fingolamod. And I think all of these studies are helpful when we're counselling patients about what to move on to after discontinuing natalizumab. Treatment decisions in women planning pregnancy. I'm being blinded by the light, but I think Ruth Dobson's just sat down at the back. Is that right? So I feel Ruth's an international expert on MS and pregnancy. So I've got Will Brown, international expert on real-world evidence, and Ruth, international expert on pregnancy, in the audience. So I'm suddenly getting nervous. But a 29-year-old woman on treatment with Fingolamod is considering starting a family in the next 12 to 18 months. She's previously been treated with beta interferon but had a disabling relapse. And she wants to know what to do about her DMT and what impact DMTs might have on her family planning decisions. Now, relapse rates, the thought is that relapse rates fall in pregnancy and then spike in the postpartum period. But that data is really from women who are untreated and have were from cohorts of women diagnosed with MS 30 years ago, where we would only make the diagnosis if it was barn door. We weren't making the diagnosis with MRI scans. We'd wait for multiple relapses before making the diagnosis. So really modern information about the impact of pregnancy on MS is important, and particularly what the impact of these newer MS drugs might have. And this is a really nice recent study from MS Base, where they looked at nearly 2,000 pregnancies in women with MS, of whom approximately 1,600 led to a live birth. And all of these women were treated in the so-called contemporary treatment era with the sorts of drugs that we treat patients with, not just beta interferon. Now, relapse rates going into pregnancy were lower in a contemporary cohort of women. So the contemporary cohort of women are women in blue, and then in orange is women who were treated from 2005 to 2010, and green is women who were before then. And what they found is that relapse rates were lower going into pregnancy in this contemporary cohort, but there was a similar rate of postpartum relapse, which is worrying, and of course we want to avoid with our treatment. Something that's not discussed a lot is that this pattern was also seen in women who had a pregnancy that didn't lead to a live birth. So I just saw a patient with a very, very bad relapse recently this week after termination. So we've got to be keeping that in mind as well for our patients. Overall, the risk of relapse was 13.6%. So these are numbers that I think are helpful in counselling patients, and about 1 in 20 women had confirmed worsening of their disability after pregnancy. And in terms of the impact of the newer disease-modifying therapies, Tysabri, which is kind of an interesting one. I think most of us are now using Tysabri during pregnancy due to the helpful guidance we've got in the UK that supports us doing that. But if you look at women here who were treated with natalizumab, and they were compared with women on a low efficacy DMT, that's the pink, people who took natalizumab during their pregnancy beyond the first trimester, who stopped in the first trimester, or who had a washout from natalizumab, which I think most of us aren't really doing, at least where I work. And you can see what happened to the relapse rate in pregnancy with the women who had a washout from Tysabri. They actually had a higher risk of relapses while they were pregnant, so they lost that protection from relapses during pregnancy and had a higher risk of relapses in the postpartum period compared to women who were taking low efficacy DMTs or women who continued natalizumab into their pregnancy. And there's some interesting data too on Fingolamod, and of course, my heart sinks when I see someone for their annual review and they're doing really, really well on Fingolamod and they say, I want to become pregnant, because it's not safe and we need to think about other treatment options for those women. And you can see women treated with Fingolamod here with a washout in orange, with a washout in green, those without a washout in orange, but it's got a fairly short half-life anyway, and low efficacy drugs. And you can see the higher risk of relapse in pregnancy and in the postpartum period here in women who have been treated with Fingolamod. And I guess how that informs my practice is that I'm very keen to plan pregnancy with my female patients and think about moving on their treatment plan to a medicine that's going to facilitate their family planning decisions and keep them well from an MS point of view. And just a couple of last slides on serious risks of MS therapies, insights from real-world evidence. So a 37-year-old man's recovering from a bad brainstem relapse while taking dimethyl fumarate, and treatment escalation's been recommended, but he's worried about serious risks of treatment, particularly his risk of infections or cancer if he takes a strong therapy. And this is again some nice work from Sweden, using the Swedish MS registry, looking at the rate of infections in people treated with different DMTs. So the lines here, the brown is rituximab, orange is Fingolamod, black is natalizumab, blue is injectables, and the pink is the general population. And compared with the general population and with other and with injectable DMTs for that matter, treatment with rituximab was associated with a nearly twofold increase in the risk of a serious infection, which I think is what we expect, and that's certainly what I counsel patients who are going on to a B-cell depleting therapy, that they're approximately double the risk of infections compared with the general population. That sadly includes serious infections as well. That being said, of course, for the vast majority of patients, the benefits of the treatment far outweigh these risks. But I think this has been helpful in clarifying what these risks are. Now, that higher risk of infection wasn't seen with natalizumab, which I think we'd expect because it's not systemically immunosuppressive. And interestingly, they didn't find an increase in the risk with Fingolamod. Of course, the infection everyone's worried about at the moment is COVID, and this is one of the recent studies from a pooled analysis of the French and the Italian registries, and this won't be any news to you, but if you take an anti-CD20 agent, then you are at higher risk of severe COVID. I think we've known that for about a year now, and that would fit, I think, with what we know about the risk of infections generally with anti-CD20 agents. What about cancer? So we know that cancer is a risk if you give people serious immunosuppression. So if there's any nurses in the room that have been around for a while, then there was an interest in giving mitoxantrone, a chemotherapy agent for MS, quite a few years ago now, and that is clearly associated with an increased risk of cancers, including solid organ malignancies, and leukemia is the main concern. We don't really know about what the risks are of cancer with our newer MS DMTs, but they have greater immunosuppressive effects. That's why they work better for MS. And this could have an implication for cancer surveillance. But trying to prove this is really tricky because the overall risk is probably low and cancer is quite common in general, so establishing a relationship is going to be difficult. And this is more nice data from Sweden. I promise I'm not sponsored by the Swedish MS register, but they keep writing these great papers that really inform my practice, and I hope you're finding the information useful too. But they combined the MS register and the cancer register together, let them talk to one another, and they looked at the risk of a first invasive cancer, particularly in people with MS, based on their DMT. And over a follow-up period of 4 years, which is not that long for cancer, right? When we're thinking about treating MS, we're actually thinking about decades, not a small number of years. But they found that, and reassuring, I think, that there was no excess risk in cancers in people treated with natalizumab or rituximab, an anti-CD20 agent, but a trend towards an increase in risk, and it wasn't significant, but it was going in a direction of concern for Fingolamod. Fingolamod, of course, being clearly associated with an increased risk of skin cancers. That's why we tell our patients to get their skin checked every year to monitor for that. So, the newer MS drugs, in general, perform better in real-world settings. It's reassuring news. I think real-world evidence is really essential to making treatment decisions in MS, and I hope I've shown you today some examples of where real-world evidence is helpful, and it can address questions not answered by the trials. And I've said to you to put your Excel spreadsheets to work and generate some real-world evidence of your own. And that's our team at Queen Square, and when we're all allowed to get together and things. Great. Thank you for your attention.